Hello, my name is Dr. Shanda Blackmon. Welcome to the Baylor College of Medicine Lung Institute podcast series. We're here to communicate with all of our care providers, our learners, and our community, as well as patients, about how to improve lung health, how to educate you and all of the people around you about ways to prevent lung disease, treat lung disease, and maintain lung health. Hello, and welcome to the Baylor College of Medicine Lung Institute podcast. Today, we're here with Sunjay Devarajan. He is our expert, not only in many different areas of pulmonary medicine, but especially in traction bronchiectasis, cystic bronchiectasis, and other forms of bronchiectatic disease. Today, we'll be talking to him about bronchiectasis, the disease, how it presents, how we treat it, and what's coming down the pipeline in the future. Welcome, Sunjay. So great to see you.
Great to see you too. Good to be back.
Yeah. So I'm glad that we've gotten together because I have a lot of questions about bronchiectasis. I know many people who've had COVID and they have traction bronchiectasis from scar tissue. As a thoracic surgeon, I see people who have cavitary bronchiectasis and it's refractory to treatment and we have to do surgery for that.
Right.
But I'm really eager to hear what your perspective is and how you treat it. So let's get started. Tell me a little bit about how you got interested in treating patients with bronchiectasis.
Yeah, thanks for the question. Like so many things great in life, you just kind of happen upon something that's interesting. So I had a mentor in my residency, Dr. Ann O'Donnell, who is kind of a world-renowned bronchiectasis expert. And it at the time, it was like a very sort of mysterious sort of disease, and I don't think I even really got a good understanding of what it was. But it was my interest in cystic fibrosis, which is one of the most common causes of genetic bronchiectasis, that kind of got me into the mix. So I had some really great mentorship through Dr. Marcia Katz, who was the former director of cystic fibrosis here.
Yeah,
and
she's a legend.
Legend, and unfortunately passed recently from pancreatic cancer. We miss her all the time. And then her in waiting, Dr. Tara Barta, who is now my clinical mentor in cystic fibrosis. So I've been in the cystic fibrosis space for quite a while. And to me, that's sort of like bronchiectasis 101. How do you care for these patients? Some of the more aggressive bronchiectasis management is in that group. And then it was kind of just a practical thing. I just found a lot of patients had this disease. And I was like, wow, CF is pretty niche. It's pretty rare. We don't have that. There's a limit to how many patients there are out there with that.
Thankfully.
But bronchiectasis, the thing about it is it's a common sort of endpoint in the lungs for many, many different diseases. So, patients can have rheumatologic disease, rheumatoid arthritis, Sjogren's disease, lupus. They can have inflammatory diseases that sort of lead this to happen. Old infections, so if you look worldwide, tuberculosis is the number one cause of bronchiectasis, cystic bronchiectasis that you may have had to operate on to remove for source control purposes.
Yeah.
You got a lot of genetic diseases, chronic aspiration syndromes in people with stroke or swallow dysfunction. And the list kind of goes on. And so because of that, it tends to be a really heterogeneous condition. And so you mentioned traction bronchiectasis, which is like one subtype that we deal with, which is seen in, interstitial lung disease, for example, IPF. And
That's IPF is what?
IPF is idiopathic pulmonary fibrosis.
Good.
And so in that situation, you have somebody who basically has lung scarring fibrosis that essentially kind of tethers those air passages open and creates the bronchiectasis in the lungs. But that's managed very, very different from, let's say, what we call suppurative or like infection-related bronchiectasis, where there's a lot of pus and recurrent infections. And those types of cases are managed very, very differently, which creates a challenge.
So how do people end up in your clinic? Do people just know that they have a bad infection? They go to their primary care doctor. The primary care doctor feels like they've exhausted all their resources, and then they get maybe a CT scan of their chest, and they see, wow, this isn't resolving, or, oh, there's a cavitary lesion, or, oh, there's this chronic infection that's sort of, boiling up inside the lung.
Yeah, I think you kind of nailed it there. So, the symptoms can be very blasé, very regular. They can present like the way COPD might or asthma might. So it's often, I would say it's probably very underdiagnosed because people just lump it in with asthma. They treat it with asthma inhalers. Patient kind of improves and they move on. But really, we're talking about a chronic cough that's often productive, of sputum that's of a phlegm that's of different color, often yellow or green. Mm-hmm. And if you culture that, you might pick up something like Pseudomonas, which should be a telltale sign there's something structural going on in the lungs you got to think about.
Or something chronic that's not really being treated.
Exactly.
Yeah.
And you can diagnose bronchiectasis through X-ray if it's sort of bad enough, but we think of X-ray as not being really sensitive enough to pick up on a lot of those subtle structural changes. And you're right, CT scan is often the method of choice to pick up on these patients and give you a picture as to where it is, how significant it is, and the thing on top of that to sort of tell us how severe it is often the pulmonary function testing.
Now, as somebody gets bronchiectasis and it starts sort of destroying the lung, do they ever heal from that, or does it turn into scar tissue, or does that cavitary area stay forever until some surgeon comes along and cuts it out?
Yeah, that's a great question, and I think that we know some things. I think the answer is partially yes, partially no. It is reversible. It's not reversible. So there's actually some really interesting data in kids. So in the genetic diseases like CF, we've got these revolutionary medications out there. And so if you have somebody who's been coming along, 7, 8 years old, has started to develop bronchiectasis in the lungs, they get put on these kind of game changer medicines, and you scan them later on, these patients actually have resolved some of these areas, which we never thought was possible.
Yeah.
But unfortunately, in most of our folks who are adults, we tend to think of it as kind of remodeled lung that's not really capable of fully going back to normal. Although you can see like improvements in the CT scans, mostly in the way of, there's less like phlegm and mucus that's plugging those air passages that are enlarged.
Yeah.
And when patients are on treatment and they're under control, a lot of times the CAT scan will look markedly different, markedly improved from where they were when they started.
Now, besides these drugs, and what else do you offer these patients for treatment? I mean, do they end up with postural drainage? Do they end up with nebulized salty water, inhaled, or what kinds of treatments do you give them?
Yeah, that's a great question. I think like so many things in medicine, you always want to look for a root cause.
Okay.
And so if it tends to be, something like rheumatoid arthritis, there's actually a percentage of patients who present with bronchiectasis who actually have rheumatoid arthritis as the underlying cause, for example. And it might be, incumbent upon me to check that blood work, and if I find it, that could totally change the outlook for that patient. They get put on modulating, immune-mediating medicines, and the lung disease is sort of stabilized.
Great.
But in patients, like let's take idiopathic bronchiectasis. We don't really know what the cause is. All the treatments are really geared at, I would say, two things, which is one, the big one is improvement in quality of life. So coughing all day, producing sputum, disrupted sleep, recurrent infections, these have an astounding effect on quality of life of patients. Mm-hmm. And so that's my number one. I'm really trying to find things that can help them in terms of improving their day-to-day symptoms.
Oh, that's great.
And then the second thing would be, okay, what can we do to avoid kind of flare-ups of the disease? Because there are flares that happen, mm-hmm. like in other lung diseases like asthma and COPD. And like those diseases, really, those flares are really the way by which people kind of deteriorate over time. Yeah. And so it's really important. And if you look at all the clinical trials, this is like a really, really big primary thing that we try to do, which is try to reduce these flare-ups, over a period of time. And as part of that, and I would say a big part of that is, rightly as you mentioned, this airway clearance thing, airway clearance therapy, or ACT. So what is that? It's really, unfortunately, it is kind of a Band-Aid approach. It doesn't really get to the underlying problem in many circumstances. But what it does is it helps people clear out this mucus that's sort of building up in these architecturally messed up lungs. And when you help them do that, either using medicines like bronchodilators, hypertonic saline, which is high saltwater solution, almost resembling ocean water. That's how concentrated it is. Using mechanical devices, maybe handheld things that they can blow into. You may have seen the flutter devices that help vibrate the chest, loosen up mucus, all the way to big flight jacket-looking vest things they can wear that vibrate the chest and help help with the cough. There's a lot that we can offer these patients to help with these day-to-day symptoms. And what we have found, and what the literature kind of shows, is if you can get them on a nice stable of medicines, you can not only improve their quality of life significantly, but you can reduce these flare-ups, and you can help them survive longer, live more, flourishing lives by doing stuff like that.
That's great. So when people come to you and it looks like they have end-stage disease, how do you make that decision about whether or not you refer them for surgery?
Yeah, that's a great question. And I think there's a couple of ways to think about the surgery bit, which is, do they have a focus of bronchiectasis? Because those are the ones where, surgery really could have an impact. If there's one kind of trouble spot, and we see this in folks who've had old tuberculosis, for example,
right,
where they have one area of their lung that's kind of destroyed, calcified, and, may not even really be participating much in what the lungs are supposed to be doing. And if they get recurrent infections, you get scans, and that's the area that's problematic, yeah, I think it's very, very wise. Patient selection is everything, as you know that as a surgeon. But I think getting a qualified thoracic surgeon to look at the scans, meet the patient, and kind of see how can we approach this surgically, perhaps to remove part of a segment or perhaps an entire lobe that might completely change the outlook for these patients.
Yeah, I would say if a patient was looking for someone, they should find a board-certified thoracic surgeon.
Agreed.
And those are some of the most difficult cases that we do. Those patients can be the sickest, and it's not just a matter of taking out the healthy, minimum healthy lung and only the diseased lung, but doing what we call an anatomic resection, where we staple off that bronchus, that part of the airway tree that's going to the infection, treating that area specifically. And then a lot of times what we have to do is put a piece of muscle over that area because it's not healthy tissue and it doesn't have normal healing.
Right.
And we have to bring healthy tissue there to help it to heal. So it's not just a straightforward surgery. It's often more complex than it looks.
Yeah, and I've been shocked at the patients that I've referred. I mean, when I was in training, most of these were open procedures, and now there's so much cool stuff happening with mini VATS procedures and robot-assisted procedures, and the recovery time for some of my patients has been absurdly low, like way less than I would have ever thought. So I think that, I think always being, maintaining those contacts with, board-certified surgeon makes a lot of sense. And it can certainly help with the source control problems a lot of these patients deal with. And then you have, patients who are more severe. And, one way is to sort of, how do you determine severity? It's going to be how frequent they're having these flare-ups. And then you can just look at numbers too. You can look at, how much are they desaturating a lot on the oxygen front when they're doing their walk? Are they starting to retain carbon dioxide, showing that the lung's having a problem ventilating? Or are their pulmonary function tests like getting pretty low? And in those cases, bronchiectasis patients are eligible for lung transplantation. So
they don't have cancer.
Right.
They just have an infection.
Right.
You treat the infection, and it's maybe too extensive for surgery. It's not just one little focal area. It's disseminated throughout the entire lung.
Right.
So those are the types of patients that you'll send for lung transplant.
Exactly.
And do you do 2 lungs or 1 lung?
Yeah, that's a great idea. So because it's more of a sort of an infection-related process, it's smart, and I think the outcomes data is better on people who do both lungs, as opposed to single. And there is some, in other diseases like interstitial lung diseases and stuff, where infection is not as big of a feature. There's more space to offer single lung in those patients.
Yeah, so we talked to Gabe Lohr earlier about lung transplantation, and he said that we're projected to do over 120 lung transplants this year. So I think one of the things that we're seeing is more minimally invasive types of surgery for lung transplant even. We've done a couple of robotic-assisted lung transplants. Wow. We've done some really novel approaches to optimizing the lung, maybe before it goes in, to try to make it better. So the lung transplant program is really helping to give you more solutions for your patients. And I know we've also done a podcast with Julina Onkasawan, who works at Vocal Cord, bringing the cords together, and her work is helping us to prevent people from aspirating from long-term vocal cord denervation.
Right. Amazing
So that's
stuff.
really exciting. A lot of interconnectedness of these different podcasts. I think probably the audience is going to have to listen to the whole series to get the full picture and be an expert in the lung. So what do you do? What do you think is coming down the pipeline? What do you think is the future of bronchiectasis treatment?
Yeah, that's a great question. And, kind of going back to the root cause bit, I mean, there's been a lot of models to show, I'm talking about like scientific models to show like how people develop bronchiectasis. And as I mentioned, it's sort of a common endpoint to many, many different processes. So it could be an infection that drives it. It could be an inflammatory thing. And so there's this model called the vicious vortex, which we use, which shows that really at any point in the process, this sort of mishmash of arrows pointing at each other can sort of be the origination of where the hit to the lung happens, and then it can take on the sort of vicious circular approach. So in that, one of the things that we've looked at is the role of inflammation. And I would say we're thinking about bronchiectasis these days. If you read the literature, kind of what I'm contributing to, what others are contributing to, the way we're thinking about it now is almost the way we've thought about asthma now for like the last 20 years, which is this endotyping thing. What do the blood tests show? Do they have high eosinophils? Do they have high IgE levels? On the bronchoscopy samples, is there a lot of neutrophil activity, like these immune cells?
Right.
And so actually some of the more promising treatments are pure anti-neutrophil elastase treatments. So neutrophils make a lot of enzymes that basically, the way the neutrophil works is it goes to the air passage or wherever it's going, and it just basically self-destructs. It releases all of its internal contents, which not only kill the bacteria, but it destroys the lung. And so when this goes off the rails, you can actually get lung damage that your own body creates. It's sort of
sort of like napalm for the lung.
It's a friendly fire thing. Yeah. It's a friendly fire thing. And so probably there's actually medicines being reviewed by the FDA right now, which there was the paper, the phase 3 study on this drug was published in the New England Journal just a couple of months ago. And it looks like it's going to be the first FDA-approved treatment for bronchiectasis ever. So we are really excited about that.
It's really exciting.
Yeah, and there's a lot of similar medicines in the pipeline looking at sort of this approach to the immune system. What can we do not only to kind of impact like the bacterial infection type stuff that causes bronchiectasis to develop, but maybe actually reducing the body's own inflammatory processes that might allow these patients to kind of retain their lung function a bit better. So I think the future is pretty exciting. Yeah. There's a lot of interest from industry on this, is what I've noticed, and I think this is just the beginning of a host of a line of therapies against bronchiectasis.
That's great. So if you're a parent and you think you have a kid with bronchiectasis, or if you're an adult, is there a different place that you call, a different place that you go? How do people find you, and how do they get to you? Can they self-refer to you, or do they have to go through their primary care doctor? What's that pathway look like?
Yeah, that's a great question. If there's any questions about where to go, you can actually, I don't mind people emailing me directly, sunjay.devarajan@bcm.edu. I'm happy to help point you in the right direction about where you might be seen. But, in this insurance-driven world, sometimes you do have a primary care gatekeeper before you can be seen by, a bronchiectasis specialist.
Yeah.
But, if you have a plan where that's kind of allowed directly, happy to visit with you, or have my colleague, Dr. Bartow, visit with you as well.
That's great. And you guys go to Texas Children's as well as to Baylor St. Luke's Medical Center.
That's true. For our, we do have kind of Texas Children's pulmonary care is state of the art. It's actually considered the best pulmonary program in the entire country, which is saying something.
Of course.
But we work very, very closely with them to transition patients over to the adult side. And certainly from in the hospital setting, yes, we do cross over and see patients there.
And then you see people in the McNair Clinic, the Baylor Medicine Clinic, that's just right off that 288 spur.
That's
it's
right.
Quick and easy to get to. You don't have to go through the med center.
That's right.
It's easy entry, easy exit without so much traffic.
That's right.
Yeah.
And if you want to play soccer after your clinic visit, we've got some nice turfed fields out there for you.
Yeah, we had a Lung Institute kickball game there last week. It was really fun. All right. Well, thank you so much for joining us today for the on-air podcast series with Baylor College of Medicine Lung Institute with Sunjay Devarajan talking to us about bronchiectasis. If you have questions, please call 713-798-LUNG, or you can email Dr. Devarajan. Thank you. Have a great day.
Thanks for having me.